Welcome to our module on upper airway disease with a focus on brachycephalic airway syndrome. In this module, we'll cover a few things related to upper airway disease: emergency airway management, brachycephalic airway syndrome, laryngeal paralysis, laryngeal collapse, epiglottic retroversion, and then, because the cats feel neglected with this lecture, we'll talk a little bit about cats and airways as well. So a pet comes into your clinic with a respiratory emergency. They can't breathe. First thing you want to do is try to figure out where it's coming from. Is it an upper airway issue or is it a lower airway issue? Is it their larynx? Is it a brachycephalic dog? Or could they be in heart failure? Or could they have severe asthma or other lung or lower airway disease? Since the focus of this module is upper airway disease, we will stay with that. Ways that you can differentiate between the two: stridor versus stridor. Is it high-pitched? Is it low-pitched? Is it inspiratory or is it expiratory? Where are those signs coming from? That can help you differentiate between the different type of airway obstruction and the location. So the pet has come in an airway crisis. What do you want to do? You may want to do active cooling if the pet is hyperthermic, if this is one of those heat stroke bulldogs. You may want to administer steroids if it's appropriate to that pet to rapidly decrease any swelling in the airway. Approximately 1 milligram per kilogram of a prednisone equivalent. So usually in our clinic, we'll do dexamethasone 0.1 milligram per kilogram IV, and then sedation. A rapid sedation protocol that doesn't cause too much of a cardiovascular depression. You want these dogs to keep breathing. So acepromazine and butorphanol are usually two of the medications we use very frequently. And then you want to secure an airway. Very frequently, with some sedation and some cooling, these guys don't need to have their airway secured. But if they do, you'll certainly want to start with an endotracheal tube. First things first, you do your best to just place that endotracheal tube. Sometimes you will need assistance with that if there's a lot of edema back there, a stylet, certainly a laryngoscope, and a couple of extra hands. If you're unable to do that, then you may want to do a tracheotomy, and we'll discuss that a little bit more. Radiographs are very important, particularly for looking at the lungs, but you'll only want to do that once your patient is stable and you're able to get those x-rays safely. If you're in general practice, I hope you never have to place a tracheostomy tube, but if you do, you should be prepared. You should be prepared with an endotracheal tube, and that can be cuffed or uncuffed, double or single lumen. In a pinch, you can even use an endotracheal tube and cut it, but again, that's not exactly perfect, but it may get you from your clinic to an emergency clinic safely, so you can certainly do that. The size of the tube should be less than or equal to 3/4 of the diameter of the trachea and 6 to 7 tracheal rings in length. So imagine the size of endotracheal tube you'd be placing per os, and then decrease that size a little bit. What are the items you'll need to place a trach? You'll certainly need some clippers, scrub. You'll want towels to place under the neck to make the trachea a little bit more prominent. Ideally, some sort of surgical pack, so you can have a scalpel, some hemostats, and some scissors. Suture material, certainly, as well as umbilical tape to secure your tracheostomy tube once you're all done. So let's talk more about brachycephalic airway syndrome. You'll certainly be encountering this in practice. Very often there are two types of presentation of these bulldogs or pugs. One is that emergency management, which we've already covered, and the other is the younger dog who's just making some noise when they breathe, or even a younger dog who hasn't been spayed or neutered and the owner wants to talk to you about potential brachycephalic surgery. First things first, what are the elements of brachycephalic airway disease? Number one, from front to back, stenotic nares. Very, very narrow nose. You can see that straight away. An elongated soft palate is probably the most critical portion of this disease process, right? The soft palate is not just too long, it's also too thick. And so even when they're trying to breathe and the epiglottis has flapped down, think of the epiglottis like a drawbridge, right? The epiglottis goes down when they're trying to breathe. If the soft palate is too long and too thick, it's still going to be in the way of the airflow. So elongated soft palate. Next part is eversion of the laryngeal saccules. When I'm talking to an owner about the saccules, I refer to them as little pockets in the back of the throat behind the larynx. That the pockets should be in, just like the pockets in your jeans. But when a dog is working really hard to breathe, that pressure pulls the saccules out as if you turned your pocket inside out. So those pockets are now in the airway and creating more turbulence. Other things that can happen: tracheal hypoplasia, or a narrowed trachea, very common in bulldogs. There's not too much you can do about that. And then laryngeal collapse. Laryngeal collapse is considered the end stage progression of brachycephalic airway disease, worth talking about as well with clients. So a lot of questions that they might be asking you. At what age should brachycephalic airway surgery be performed? Should you be doing it at the time of spay or neuter? Should you be doing it when they're mature? There's some research to suggest that doing brachycephalic airway surgery, at least the nostrils, when they're very young, may actually help prevent the progression of the other signs. That if you can make them breathe better through their nose, there may be less turbulent airflow, and they may be less likely to develop that severely hyperplastic soft palate. Again, there's no guarantee. So I do always tell owners, if they have brachycephalic airway surgery, either the nose or the palate or both, at the time of their spay or neuter, they may still need surgery when they're all grown up. Another question: how severe are the signs before you consider surgery? Of course, you don't want to let it get to the point where they're coming in on a gurney with heat stroke and unable to breathe. I tend to think if you can hear the dog and you can hear it coming with your eyes closed, you might want to consider brachycephalic airway surgery. If these are dogs that get very upregulated and stressed, and it takes them a long time to calm down and stop having noisy breathing, you might want to consider surgery. If these are dogs who wake themselves up in the middle of the night because they can't breathe, you might want to consider surgery. I would prefer to do brachycephalic airway surgery on a kind of prophylactic basis rather than have them come in that emergency situation. Other questions that I get asked a lot are, how do you do brachycephalic airway surgery? Do you use a laser? Do you use a scalpel or scissors? Do you use things like ligature? There are studies looking at all of these techniques, and all are deemed appropriate. Other things that we have questions about, which there's a little bit more research on these days, are saccules. Traditionally, sacculectomy or removal of those laryngeal saccules was indicated, but there's some research to suggest that if they aren't severely everted or causing a lot of obstruction of the airway, it may be better to leave them in place. That sacculectomies may actually cause more morbidity. Another thing which I think is frequently ignored is the confluence of GI disease, gastrointestinal disease, and brachycephalic airway syndrome. Very, very common that these little Frenchies, they're super cute, they have trouble breathing, and they're regurgitating all the time. It becomes a vicious cycle. They regurgitate, they can't breathe, they aspirate, they get pneumonia. Why are these GI signs happening along with the airway syndrome? What we think happens is that when you have trouble breathing and you work to breathe, the pressure differential between the chest and the belly is off. And so the stomach can actually be more inclined to have regurgitation or reflux, or in the worst case scenario, a hiatal hernia, because of the extra work to breathe. So a lot to talk about. It's not just all about the nose, but all very important things to discuss with owners. One reason why a pet may present to you in a real airway crisis is laryngeal collapse. This we consider an end-stage airway disease and a progression of brachycephalic airway syndrome. Stage 1 of laryngeal collapse is actually saccule eversion, laryngeal saccule eversion. Stage 2 is loss of rigidity and medial displacement of the cuneiform process of the arytenoid cartilage. It's a lot of words. Basically, what it means is that a portion of the arytenoid cartilage has collapsed inward, but it's not completely collapsed. Stage 3 is complete collapse, so collapse of the corniculate processes of the arytenoid cartilage and complete loss of the dorsal arch of the rhemoglottis or the laryngeal opening. In the worst situations, you look back there with your laryngoscope, and instead of the nice open larynx, you actually see that the laryngeal cartilages are crossing over each other. So it is loss of integrity of the larynx itself, and that's why we call it end stage, that there's nothing you can necessarily change or fix. Those cartilages are just completely abnormal, and they are at that stage of collapse. So what do we do about laryngeal collapse if it is indeed end stage? There are some studies that show that you can remove portions of the larynx. Usually not something we recommend because the risk of aspiration pneumonia then becomes so very high. What we will recommend in these dogs is to perform the other safer portions of brachycephalic airway surgery, the nose, shortening the palate, in order to see if we can do enough to allow some airflow through that larynx. Another option is a tieback. We'll talk a little bit more about that when we talk about laryngeal paralysis. Very, very small studies, but it has been shown, and I've done a couple, that with dogs with laryngeal collapse, you can actually stitch those cartilages to the side of the airway to open it up again. Now keep in mind that the risks with any type of brachycephalic airway surgery, or really any airway surgery, is pneumonia, aspiration pneumonia. So with laryngeal collapse, what you can do is try to open up all of the tissues around the larynx as best you can. So do that nares opening, do that staphylectomy, shorten the soft palate to try and open up the airway as best you can. If that doesn't work, there are some surgeons out there who will remove portions of the laryngeal cartilages. Another option would be to do a tieback. We'll talk more about that when we talk about laryngeal paralysis. But do remember that the complications and the risks of any of these airway surgeries include worsening the swelling, needing to do a tracheostomy, either temporary or permanent, or of course, aspiration pneumonia. So we'll take our focus away from the brachycephalic dogs for a moment here and talk about laryngeal paralysis, or LARPAR. There are two very common presentations of this disease process as well. One is an older large breed dog, often a Labrador, who just makes a lot of noise when they breathe. Maybe they get winded more quickly. Maybe their bark has changed, but otherwise they're doing pretty well. There are other dogs with laryngeal paralysis who have more of an acute respiratory distress. They have inspiratory dyspnea and airway obstruction because of this laryngeal paralysis. These dogs will also have a voice change, and they might have coughing or gagging, particularly when drinking. Signs are often exacerbated by excitement, anxiety, and change in temperature. Some of these dogs might also have other neurological signs, so very important thing to watch out for when you see a dog with laryngeal paralysis. So you're seeing a dog with laryngeal paralysis, most likely to be a large breed, a Labrador, a Golden, a St. Bernard, or an Irish Setter. Usually older dogs, more male than female. However, there are some congenital or hereditary types of laryngeal paralysis. What is the cause of laryngeal paralysis? It can be caused by a mass, a thoracic or a cervical mass, pressing on the nerves, the recurrent laryngeal nerves to the larynx. There can be trauma to that nerve, so a bite wound, something like that. There can also be a neuropathy or a myopathy specific to the area. Also, hypothyroidism is known to be a risk factor. There is another type which is called idiopathic. When something is called idiopathic, it means we don't really know why it happens. But there is research coming out to suggest that these idiopathic LARPAR dogs may not be idiopathic at all, and that it might be part of a constellation of a generalized progressive polyneuropathy, that over 80% of dogs with laryngeal paralysis, over the time of a year, may develop other neurological signs like weakness, scuffing of the back legs, ataxia, other clinical signs associated with it. Doesn't mean we shouldn't treat laryngeal paralysis, but it is important to know that it's probably not idiopathic. So what do you tell an owner when you've diagnosed a dog with laryngeal paralysis? Depending on the severity of their signs, you may be able to manage this disease process medically with anti-anxiety medications, ensuring that they don't get overheated, limiting exercise. There are also some dogs who will seem to be doing very well with medical management and have a more acute respiratory crisis. Of course, those dogs with respiratory crisis do require surgery, and it can be an emergency surgery. Other things to discuss with owners are the risks of aspiration pneumonia. Given that laryngeal paralysis is a disease of the larynx being closed, when the recurrent laryngeal nerve is not working, that muscle, the cricoarytenoideus dorsalis, doesn't open up the larynx with breathing, so everything is snapped shut. Our treatment is an arytenoid lateralization, meaning we go in one side, usually on the left, and open up one side of the larynx permanently with sutures. That's great, it allows air to go through, but also it does create a risk for aspiration pneumonia. So make sure before you refer, before you do this surgery, that these are owners who are going to be comfortable with about a 20% risk of aspiration pneumonia. May not be fatal, but it certainly is something where they will have to modify the dog's activity, eating, drinking, and monitor them very closely for the rest of their lives. So we've talked about brachycephalic airway syndrome and we've talked about laryngeal paralysis, two very, very common disease processes. But what about an imposter? A dog that comes in that has increased respiratory noise, that might have a very strange pattern of breathing where they sound mostly normal at times, and then all of a sudden it seems like the airflow just stops. They'll breathe normally and then they will completely and acutely obstruct their larynx. It may not be a dog who fits the bill. It might not be an old Labrador. It might not be a Frenchie or a pug. This might be a case of epiglottic retroversion. Often small breed, older dogs, sometimes we'll consider this a secondary disease process like a Yorkie with tracheal collapse. What happens in these cases, in these dogs, is that the epiglottis, instead of staying down when they try to inhale, actually flips backwards, epiglottic retroversion, when they try to inhale. So, what can we do about that? And how do we diagnose these cases? Diagnosis can be very difficult because this is a dynamic process. If you sedate or anesthetize a dog with epiglottic retroversion, you might not even see it. So the diagnosis is very much by signalment and presentation, watching them. Also, if you lightly sedate these dogs and try to observe the back of their throat, then you may be able to catch that epiglottis as it flips backwards. Sometimes treatment is a good way to diagnose a problem as well. You can put temporary sutures or epiglottopexy sutures between the bottom of the epiglottis and the base of the tongue to hold the epiglottis down and see if that resolves the problem. If the dog does resolve and gets better, then you may want to do a permanent epiglottopexy where you remove a little bit of tissue from the base of the epiglottis and the top of the tongue and suture it permanently in place. Much like our other treatments for any type of airway obstruction in which we open up the airway permanently, there's definitely a risk of aspiration pneumonia with treatment of epiglottic retroversion, but it's way better than the dog not being able to breathe at all. And we can't forget about cancer, unfortunately. With airway disease, as with everything else, laryngeal tumors can also be imposters. Probably the most common reason why a cat might have a laryngeal obstruction or an airway obstruction. Squamous cell carcinomas are most common in dogs for laryngeal tumors. Also, tonsillar tumors, tonsillar squamous cell carcinomas can also cause laryngeal obstruction. Lymphoma is probably the most common neoplastic cause of an airway obstruction in a cat. Most of these types of tumors are locally invasive, but they can metastasize. So other diagnostics such as, yes, your sedated airway exam, but x-rays, ultrasound, and advanced diagnostics can be very helpful in these cases. So that was our module on airway disease with a focus on brachycephalic airway syndrome. Next up, GI surgery and GDV.